Think your fasting insulin gives you the full picture? Think again. Your pancreas pulses insulin every 10 minutes, so that normal result could be a lie. There's a better way to uncover hidden metabolic dysfunction, and it starts with a test most doctors overlook. Hi, I'm Marc Bates. I'm a metabolic health coach, and this is part of my question and answer series. Why fasting insulin may mislead you and what to test instead. We'll cover the whole area. And by the way, this question came directly from a listener, and so we thank you for asking, right? So here's the question. I'm not sure that fasting insulin is a good metric, since the pancreas beta cells squirts insulin in about every 10 minutes, and you can't see numbers to trust. You can get high numbers immediately after squirt or low immediately before the squirt. Maybe C-Peptide would be better. I'm not claiming that, I'm just thinking out loud and would be grateful if you'd correct me. Thank you. I'm not going to correct you. You're absolutely right to think critically about the reliability of fasting insulin measurements. And you're not alone in that skepticism. Well, let's walk through the science behind your concern and clarify where C-peptide fit into the picture and where fasting insulin may be a better result. Okay, so let's start with insulin secretion. Pulsatile and rhythmic. Yes, insulin isn't released as a steady trickle. It's secreted in pulses. These can occur every 4 to 15 minutes, modulated by ultradian rhythms and influenced by insulin-resistant circadian biology. Okay, so yeah, there are pulses here, and there may be high points and low points and such. Okay, but a single fasting insulin snapshot can land on a peak or trough in that pulsate rhythm. As such, a fasting insulin value might not fully reflect total insulin exposure or secretory capacity. So that is a concern, right? So, what about C-peptide? Is it a more stable marker? Well, C-peptide is released in equal molar amounts with insulin because both are products of the cleavage of proinsulin. However, it has several advantages over insulin. It has a longer half-life, about 30 minutes compared to insulin's 5 to 6 minutes. It's not extracted by the liver, making peripheral levels more reflective of pancreatic output. It's less influenced by acute clearance variability or hepatic metabolism, and it's stable over short-term fluctuations, making it useful for assessing beta cell function and total insulin production. Well, it sounds like that would be the one to go with. Okay? But let's get a little deeper. Here's a breakdown of when and how to use fasting insulin, C-peptide, and something we hadn't talked about before, postprandial insulin testing. Okay, let's talk about fasting insulin. What it tells you. At baseline insulin levels, helpful for early identification of early resistance. Okay, so while it does pulse, and if you catch it right before or right after a pulse, the amounts may go up and down a little bit, but it's not that dramatic actually, where it throws the numbers completely out, makes the numbers completely useless. Okay? Initial screening for metabolic dysfunction, especially when paired with fasting glucose for HOMA-IR. This is the key reason we use fasting insulin, because we need it for the HOMA-IR calculation. It really works for especially for our clients who appear lean but are metabolically unhealthy. A lot of people just never thought about testing their fasting insulin because they don't have a lot of fat around the middle. They're going, I'm healthy. And it helps us to compare pre and post lifestyle or diet interventions. If you're on a metabolic intervention and the goal here is to reduce insulin so that you're not fostering insulin sensitivity, fasting insulin is actually a very good test for this. Once again, the amount every 5-10 minutes will vary, but it's not going to vary so much that it really matters, okay, for most of these tests. Because remember, you're doing this after a fast, right, which is an 8 to 12 hour fast, so you should not have any true pulsations in the insulin before you take the test, right? And that's the key point there, okay? So what this is giving you is the fasted insulin, and that's the key here. We're looking for the fasting insulin amount, and we want to pair it right with fasting glucose to calculate the HOMA-IR. So once again, this is after an 8 to 12, preferably 12 hour, the longer the better, fast before we pull the insulin and the glucose. Okay? And what you're looking for is a HOMA-IR under 1.5. So that's why we use that calculation. Okay, let's talk about C-peptide for a minute though. See what C-peptide tells you. It's a true endogenous insulin production over time. And we're not looking for insulin over time. We're looking for that fasting insulin specifically in this specific case, right? But over time, this is a good indicator. It's useful in variable or suppressed insulin readings. There are reasons why we don't get a good insulin interpretation, and so we want to respect that. It's best used for clients with a history of erratic fasting insulin. It's those who are using insulin or insulin analogs, right? Confirming pancreatic reserve or beta cell burnout, right? So that if that's an issue, we do want to confirm that with the C-peptide. And suspected factitious hypoglycemia from insulin misuse. If you're injecting, and we see this with injected insulin, if you're getting just numerous symptoms of hypoglycemia, it could be the way you're injecting the insulin, okay? So how to use this? Should be fasted, ideally drawn with insulin and glucose. So you want to get your C-peptides at the same time you're getting your fasted insulin. Normal reference range is 0.5 to 2, right? But it is lab dependent, so don't worry about the normal reference range. And your interpretation here. If your C-peptide is low and your fasting insulin is low, so you're using the two together, your beta cell failure may be very high, right? Look into that. If C-peptide is high and your fasting insulin is high, you have hyperinsulinemia. You have insulin resistance. If it's low and your fasting insulin is high, it's pretty rare. Recheck the lab work. Okay? And if your C-peptide is high but your fasting insulin is normal or low, it may reflect a postprandial insulin resistance or stress. So there are good reasons to pull all this, and actually you probably should pull C-peptide at the same time. Most labs do. All right? So just keep that in mind. All right, here we go. Postprandial insulin testing, or this is also known as the Kraft test. What it tells you is how quickly and how much insulin is produced in response to glucose, an early marker for insulin resistance before glucose is abnormal. It's best used for clients with normal fasting insulin and glucose, but symptoms of metabolic dysfunction. Detecting early or hidden hyperinsulinemia, especially in lean individuals or athletes. And this is a key one here. Okay, if you're lean, you're not healthy. If you're not, have any extra weight on you, or you're like an endurance athlete and you're still having problems that we're recognizing as metabolic, we might want to use this test to see what's going on with your insulin production. Okay, evaluating true metabolic flexibility. This is the ultimate test to determine how flexible you really are. Okay, it's an oral glucose tolerance test with insulin. You're given 75 grams of glucose. Then you measure the glucose plus insulin at 30, 60, 90, and 120 minute level increments. Okay, if you have an abnormal insulin curves, which may precede abnormal glucose by up to 10 years. Now, here's the problem with the Kraft test. It's a very expensive test because think of it. You got 2 hours in your doctor's office or the lab because you have to take these draws exactly on time. So, while this is probably the best test overall, it's probably one of the most expensive and one of the most time-consuming ones. Okay, so you got to keep that in mind. Okay, so real quick, here's a quick summary table. Fasting insulin, what it's best used for, quick screens, IR, and HOMA-IR, right? There are limitations to it, but it's a good baseline screen. C-peptide, it's a longer-term view. It's, yes, less useful acutely because it's longer term and it's easier to affect, but it does confirm insulin resistance and beta cell function and postprandial insulin early diagnosis of hidden IR. Okay, so if you have normal blood sugar but symptoms like fatigue, weight gain, mood swings, or sleep disruption, insulin testing reveals the truth. earlier than glucose alone ever will. Use C-Peptide as your Steadicam, fasting insulin for quick snapshot, and Kraft style tests as the slow motion playback. Would you like? Okay, so um, if you'd like more information on this, let me know. All right. So once again, I want to thank you all for watching. It's been a pleasure coming up with this one for you guys. If you have any questions, please leave them in the comments. And once again, we are a community. I get these questions from you, and this is why I produce them, because I figure if one person's asking them, more people want to know about this. So it's here. And once again, if you haven't already done so, please like, subscribe, share this with somebody who might need it. Appreciate it. Thank you so much.